Hello everybody, my name is Maxime Ronot. I'm a radiologist. I work in Hôpital Beaujon in Clichy, France. I specialize in abdominal radiology and interventional oncology, especially treatment of hepatic tumors. And today I would like to give you an overview of the different challenges that you may face during liver intra-arterial procedures. And I would like to introduce a series of software solutions that are named Liver ASSIST V.I and Motion Freeze. And you will see how this very easily used software may help you address those challenges. So to start, let me remind you something that you are very aware of, is that liver cancer is very frequent, and the incidence of liver cancer is increasing worldwide because the risk factors for liver cancer, especially chronic liver diseases, are also increasing. And it makes it the fourth most common cancer-related death in the world. Now, unfortunately, when patients are diagnosed with liver cancer, especially primary liver cancer, the vast majority of those patients will not be eligible for surgical procedures or ablation that are considered to be curative intent treatments. And it is estimated that 50% of those patients will be candidate for non-surgical procedures, and especially interventional radiology ones. And if you look at all IO procedures in the liver, in general, you will see that roughly 2/3 of the interventional oncology procedures will target liver tumors. So not only is that a frequent problem for patients, but it's also a very frequent situation for us interventional radiologists. So these are very frequent treatments that we do every day. And this is also shown by the very well-known staging systems. For instance, this one, the BCLC, that you are very familiar with, and you see that this staging system allocates patients based on tumor stage, the general status of the patient, and the deterioration of liver function, allocates different stage with different first-line treatments. And you see here chemoembolization and intra-arterial treatment in general are very at the center of the treatment of those patients. It is the treatment that is the most performed for those patients. So say you have a patient that is as an indication for intra-arterial treatment, say for instance chemo, and you will face several challenges that you need to address because you want to plan, you want to target and assess what you are going to do. So you want to identify the target tumors, and you will do that with pre-operative CT and MRI, of course, but still during the procedure you will need to identify those tumors. You will need to identify the feeders of the tumors because after all, you're doing intra-arterial treatment, so you want to go into those different feeders selectively. And then you want to define the best injection points, the injection point that will give you the best coverage of the tumor and also the less involvement of the non-tumoral liver. And at the end of the intervention of the procedure, you want to assess what you did because it will help you first be confident in what you did and also anticipate what may be the future direction for the patients. And as a general consideration, one of the main technological improvement and innovation that we have seen over the past, say, 15 years is the introduction of cone beam CT technology. And it has helped us improve for all these steps. Now, a lot of papers, several studies showed that when you compare DSA on the left and enhanced contrast enhanced cone beam CT, you will get a significantly higher sensitivity in detecting tumor. This is an example of a patient with HCC. You see on the left-hand side the angiogram. You see very well the blush of the tumor, but if you compare that with the 3D acquisition, of course, you will see the main tumor, but you also find more tumors. And this is something that we know when we compare radiography and CT or MRI. We know that 3D imaging and contrast and 3D imaging is better, and interventional radiology, it's also true for us. So sensitivity for tumor detection, very high. It's also known now, and several studies have shown that when you want to identify the tumor feeders, you will improve when you use contrast enhanced cone beam CT, and you will probably go for, as you can see here, 2/3 of feeders detection up to 80 to 85%. So you will gain between 10 to 20% sensitivity in terms of tumor detection, which is very important because you know that The performance of your treatment will depend on your ability to identify all tumor feeders. Otherwise, you know that you will incompletely treat the tumors of the patients. So we detect more tumors, we detect more feeders, and at the end, papers have also shown that doing just non-enhanced cone beam CT at the end of the treatment will give you a pretty good overview of the deposition of the treatment, whether it is conventional chemoembolization or drug-eluting beads. It works too. You will see, and this is a comparison here between the cone beam CT performed at the very end of the procedure and the follow-up CT performed 1 month after. So you can anticipate what you will see, and you can know whether or not you had a complete treatment for the patient. Now, this is a major improvement to the point that now many interventional radiology societies recommend using CBCT as a sign of good practice. This is something you should do. But even if you do, and if you want to do that routinely, you will face new challenges. You will gain a lot of confidence and efficacy, but you will face new problems. These new problems is that you have to do a good quality 3D images of the patients, and you have patients that may be too large to be imaged. You may have problems centering the organ, especially for the liver that is right-sided in the abdomen. You may also have, and we will talk more about that, artifacts, and especially respiratory motion artifacts that will decrease the quality of the CBCT, even though you do everything else perfectly. Now, to address the first two problems, the last generation angio suites, such as the Discovery you see here, really address that. You now have large bore detectors, you have almost CT-like image quality, so centering the patient is not that much of a problem anymore, and the quality of the images you get is really good enough for you to do a very accurate treatment. But even if the patient is easily centered and the rotation of the arm is easy and you get very nice images, if there are motion artifacts, you will not be capable of using those very nice imaging data for your treatments. And it is estimated that maybe up to 40% of CBCT are somehow degraded by motion artifacts, because patients may be too weak, too old, they may not be able to hold breath, or they may not understand what you say because they don't speak the same language as you. So you can practice with them before the treatment, but still you will have a subset of CBCT images you will not be able to use. So now you can do a new CBCT 1, 2, 3 times, but there is a problem of injection, there is a problem of dose deposition, of time, or you can just not use that, but it's a shame because I just told you before that you really need this to be better. Motion Freeze is a new software solution that aims to and manages to improve the visibility of the vessels and of the tumors, starting from a very degraded 3D acquisition because of the motion of the patients, and you will improve the image quality so that you can use that. It's not going to be perfect. It's not going to be as good as a still patient, but still you will be able to use that and to perform your treatment. We've assessed this in a recent publication that we published in European Radiology this year, and we showed that both subjectively and objectively, the use of this software improved images and made them clinically relevant. That's just one example here, very ugly degraded images on the left-hand side, and on the right-hand side, you see the exact same set of data that has been reconstructed with Motion Freeze. This is a very quick reconstruction algorithm because it adds something like 1 second to the reconstruction. So it's very easily implemented in the routine workflow. You don't have to click on several buttons. You just click one thing and then you get a Motion Freeze reconstruction. So you can view and work on these images. You can process those imaging. You can do the volume rendering easily. It's easy to see the difference. And you can also use guidance software for the intra-arterial treatments. And on the left-hand side, you see that the guidance software, they cannot identify the feeders of the tumor, and the right-hand side, they manage to regain their disability. So based on the same very blurry images, you can use them, and you will reduce the need for redo of CBCT. You will not give up on using the CBCT. So that's very important. And another thing that is important is that if you use that routinely, you may wonder, yes, but if I use that in a patient that was pretty still, is it going to, I don't know, decrease the image quality? Well, no, we also assessed that, and we showed that when you apply the motion freeze algorithm to a perfect CBCT, it will not change the images. So you only gain from the bad ones and you don't lose the good ones. This software that you're seeing here, this very ID, is called Liver ASSIST V.I. And the idea behind that is that you need to find sometimes help in identifying the multiple feeders that will feed one tumors or two targets. And we've also assessed the possible benefit of those software. We compared the visual analysis of the contrast-enhanced CBCT. I showed you we had up to 82% sensitivity for detection of tumor feeders. And we applied the new software to that, and we were able to gain 10 more points in terms of feeder detection sensitivity. So this is also very useful, and I cannot stress that enough. When you know you treat all the feeders, you know you will have a better treatment, you know you will have better results, and you can be more selective, so you will have also better tolerance of the treatment, which is key for those patients that have cancer and you want to limit their suffering. So if I just summarize what it does, starting from a contrast-enhanced image, 3D set of images, you will extract, and I will show you examples after that, you will extract the vessels, the arterial vessels of the patients. You will target the different tumors. You will tell the software where your targets are, and it will automatically detect and highlight the path between your catheter and the different target tumors. And you can do that, and then you can manipulate those images in 3D, and you can send it to your images, so you can have the superimposition of this with your fluoroscopy live always when you do. And when you move the detection and when you move the detector, it will move with you. So you have kind of a 3D roadmap all the time. We also showed that the inter-reader agreement for the identification of tumor feeders when we used this software was very high, 92%. Means that when you apply the same set of image and you ask different radiologists to identify the feeders, thanks to the software, they will pretty much be always agree with each other. And even though the data are not very large, we have evidence showing that when you apply this software to treatment, you will have an increased rate of complete tumor response after 1 or 2 sessions of chemoembolization, which is a key prognostic factor for those patients. You want to obtain the best response you can get. And when you do that, and when you apply that in routine, you may also have, which is something interesting, more confidence, I told you, probably less contrast injection because you don't need to inject all the time. You have the 3D images with you. Probably less deposition and less duration. It's a shorter procedure. One thing that one very interesting new thing that Liver ASSIST V.I does for you is the virtual injection. Because I told you need to select the best injection point, the injection point that will give you the best coverage of the tumors and exclude as much non-tumoral liver as possible, so you can have better effect and less toxicity. When you navigate through the 3D vessels that are extracted by the software, you are able to highlight to a simulation of the volume that will be injected if you were to inject here. So you can move and select what is the best compromise for you. It doesn't do that for you, which is good, so you need to think, but you will be guided through this. And this is nice for chemoembolization or embolization. It's also nice when you do radioembolization, when you want to have an idea of the volume of tumor and volume of liver that is injected with your treatment. So to summarize, you have the typical workflow on the left-hand side that you are very familiar with for chemo or radioembolization. You plan the treatment, you identify the tumors and the feeders, You guide your treatment because you want to navigate your device through those tortuous anatomy. And then at the end, you assess what you just did to make sure that you did correctly. And at each step of this procedure, you see that Liver ASSIST V.I, motion freeze, and the 3D high definition package will help you because you will, I showed you, identify more tumors, more feeders, be more confident when you navigate through them. You will compensate for the movement of the patient, so you will use more frequently the 3D images. And at the end, it's very nice to see that you're more confident and the team is more satisfied, but also the patient will benefit from that because the treatment is likely to be more efficient and less toxic for them. With that, I would like to thank you very much for your attention. I hope this presentation was interesting and clear enough for you. Feel free to ask any question.